system is a solution to a problem in evolution that resulted from the progression of life from single-celled organisms to multicellular organisms. When that happened, we generated a body plan with tissues that were far removed from where the oxygen and the nutrients came in. And in order to get the oxygen to the tissues so they could make enough energy to support the organism, we had to generate a cardiovascular system and a respiratory system in order to pull that oxygen in. Okay, oxygen doesn't dissolve very well in water, and that's one of the reasons for the evolution of hemoglobin in the red blood cells, in order to carry significant oxygen to the tissues so they can make enough ATP to support life. Remember that with oxygen around, you make 20 times more energy than without it. Okay, so we are what are called obligate aerobes. Right? We have to have oxygen in order to survive. Now, it's true that oxygen is only 20% of the air we breathe, but that's more than enough to satisfy our needs. We also have to get rid of carbon dioxide, which is a waste gas that, if it builds up in cells and tissues, creates toxic conditions that would kill them. Okay, so it's critical for pulling in air in the respiratory system to be able to do something called ventilation, which is the physical movement of air in and out of the system. Okay, fish do that by beating their gills. We do that by utilizing our diaphragm, which is a flat skeletal muscle underneath the lungs that changes shape, and when it does, it changes the shape of the chest cavity. And since the chest cavity has a fixed amount of gas in it, when the chest cavity expands, that creates a vacuum, and that's when the diaphragm is contracting. And when the chest cavity constricts, that's when we produce a positive pressure around the lungs. We blow the air out. Okay. External respiration is the movement of oxygen and CO2 between the lungs and the blood. Transport is the movement of the oxygen and CO2 in the blood. And internal respiration is the dump off of oxygen to the tissues and the pickup of the waste gas CO2. Okay? So when we're talking about respiration, we actually use it in a few different contexts. Okay? Here we're using respiration in the context of the movement of the gases to the tissues and from the tissues to the lungs, right? And from the air to the lungs. And cellular respiration is the use of oxygen inside the cells in order to produce ATP, utilizing the Krebs cycle and the electron transport system as the two legs of metabolism that benefit most from the presence of oxygen. Okay, so it's used in many different contexts. Our respiratory system is pretty simple, right? It starts at the nasal cavity, and then it runs to the nasopharynx, then the laryngopharynx, then the oropharynx. The oropharynx, then the laryngopharynx, and then it's going to go down the larynx, then into the trachea, and then into the bronchi, and then into the lungs and the alveoli, right? And we don't really get to gas exchange until we get to what's called the respiratory division of the respiratory system, and that happens beginning at structures that are called respiratory bronchioles. Okay, so from the nasal cavity all the way down to what are called the terminal bronchioles, all we're doing is piping the air into the area of the lungs that gas exchange will happen. All right, and along the way, the air gets humidified, warmed up, and filtered, and that keeps it from damaging the delicate lung tissue. Okay, so you can see here in the nasal cavity, let me use laser pointer, and let's go green, and let's go here. So nasal cavity's got these ridges. These are called conchae. They're superior, middle, and inferior nasal concha, and these are the meatuses between them. And they provide turbulent flow through the air that you inhale, and the mucous membrane in there helps to trap particulates and humidify and warm up the air. And then it's going to run back through the nasal cavity into nasopharynx, then oropharynx, then laryngopharynx, and it's going to go through the larynx, which is the voice box, then down through trachea, then it's going to hit the carina, and then it's going to go into both of the primary bronchi, then into the secondary, then the tertiary bronchi, and the bronchi will continue to split about 25 more times before we get to what are called the terminal bronchioles, and that ends the conducting division of the respiratory system. And after that, you've got the respiratory bronchioles, the alveolar ducts, the alveolar sacs, and the alveoli, and that is the part where gas exchange happens. Okay? You can see the diaphragm under the lungs here. It is skeletal muscle, okay, so we control it. However, at night, when we dream, the diaphragm continues to work, hopefully, and that's the result of brainstem activity, okay? The brainstem, through the pons and the medulla, talk to the diaphragm while we're unconscious and rhythmically innervate it so that we continue to breathe and we don't die in our sleep. If this fails, then that's a condition called central sleep apnea, right? And that can result in death. And that's thought to be a cause of SIDS, which stands for Sudden Infant Death Syndrome. And we don't really know in cases of SIDS why the brainstem fails, but it does, okay? The other type of sleep apnea you've probably heard of is obstructive sleep apnea, where while you sleep, your upper airway closes. This is a problem in the elderly and in the obese and in the pregnant. And you usually wake up from that sucking wind in order to restore your oxygen levels. And the fix for that is to lose the weight if you can. That's the long-term fix. But the short-term fix is something called a CPAP machine, which generates positive pressure, pushing air into the nasal cavity, down to the pharynx, larynx, and trach, and keeps the airway patent or open throughout the night. Problem is, it's tough for a lot of people to sleep with a mask on their face. Okay. The respiratory zone, okay, comes after the conducting zone. The conducting zone gets the gas down into the respiratory zone, okay, and that goes from the nose all the way to the terminal bronchioles, and its purpose is to treat the air, right? And the respiratory zone, again, begins after the terminal bronchioles with the respiratory bronchioles, alveolar ducts, and alveoli, and that's because those are the only regions of the respiratory system that have something called respiratory membrane, which is the endothelial cells of the lungs, and then a basal lamina, and then the endothelial cells of the capillaries, and it all ends up being less than a micron thick and perfect for the passage of non-polar gases through it, such as CO2 and oxygen, okay? The respiratory muscles promote ventilation. The main one is the diaphragm, but in forced breathing, we actually do use other muscles, okay? You're supposed to breathe through your nose. I know some people don't, but you're supposed to breathe through your nose. It is effective at warming, humidifying, and filtering the air, okay? It's a resonating chamber for speech because it's connected to the paranasal sinuses. And you know this if you ever try to close your nose and talk, you can't generate nearly as much volume. And it also houses the olfactory epithelium at the top of the nasal cavity, and that's where the first cranial nerve comes through the cribriform plate and produces the olfactory mucosa, and that's how we smell, okay? The external nose and the nasal cavity are the two components, all right? The external nose is made up of the root, the bridge, the dorsum nasi, and the apex. Underneath it are the philtrum, which are the vertical grooves that are under the apex, and the external nares, which are on the outside, and they are bordered by the alae, or the wings, right? So those are the external nares. Here's the alae, right? The internal nares are at the back of the nasal cavity, okay? There's the bridge and the root of the nose, the dorsum, right? And there's the apex of the nose, okay? Now, you might wonder, if you ever looked at our nearest relatives in the animal kingdom, you probably noticed that the nose has a different shape. In most of these great apes and monkeys, the nose is flipped up, right? And the theory, we don't have proof for this, but the theory is that we evolved this shape for the nose as a way to be able to go into the water and look for food, okay? Because you dive in the water with a nose like this, you're not going to get water straight into your nostrils, whereas if you have a nose like a gorilla, then you're more likely to flood the chamber with water, and you're going to be less effective at finding food. Also, the fact that we have less body hair, okay, and the fact that our newborns are born already knowing how to swim is thought to be evidence that we were one of the few hominids that went into the water in order to look for food. Okay, like I said, we don't have solid proof of this, but that's one of the theories that's out there. If you look at the nose, it's a combination of both bone and cartilage, right? We know the bones that make up the nasal cavity include the nasal bone and the ethmoid bone and the inferior nasal concha and the vomer, okay, and portions of the maxilla. And then the rest is cartilage, right? You've got cartilage that makes up the apex and a lot of the bridge of the nose, okay? And portions of it are dense, fibrous connective tissue. Other portions are elastic cartilage, okay? And this provides the familiar shape of the nose that we've come to know, right? The nasal cavity is divided into two chambers by the nasal septum, which are formed inferiorly by the vomer and superiorly by the perpendicular plate of the ethmoid bone, okay? The posterior nares open into the nasopharynx. The roof is the ethmoid and sphenoid bones, and the floor is the hard and the soft palate, which of course is formed by the palatine processes of the maxilla and the palatine bones. Okay? The nasal vestibule is the cavity above the nostrils. There are hairs called vibrissae that act as filters. The rest of the nasal cavity is lined with either an olfactory or a respiratory mucosa. The olfactory mucosa is on the top of the nasal cavity. The respiratory mucosa is everywhere else. The respiratory mucosa's function is to warm and humidify the air and to produce mucus. The olfactory mucosa is to provide our sense of smell. Okay. Remember that the olfactory mucosa is unusual. It contains the first cranial nerve. It is the only nerve that regrows every day. Okay, so that's unusual among nerve cells. So the olfactory epithelium provides our sense of smell. The respiratory mucosa is pseudostratified ciliated columnar. Mucus and serous secretions have lysozyme and defensins in them, and the cilia move contaminated mucus back towards the throat. Inspired air is warmed by plexuses of capillaries and veins, and the sensory nerve endings are going to trigger sneezing. And you can see here again a close-up of the structures, right? There are the conchae, and there are the meatuses between them. This is actually connection to the middle ear. This is the opening of the eustachian tube here. Tonsils at the back of the throat guard against infection, right? And these are just collections of connective tissue that are populated with macrophages and lymphocytes and so on. The hard palate here, anterior 2/3 maxilla, posterior third palatine bone, soft palate behind it, it's ending in the uvula, right? The purpose of the soft palate is when you swallow, it flips up and it blocks food and water from getting into the nasal cavity, okay? At the same time that the epiglottis closes over the glottis, which is the opening through the vocal cords, and directs the food down the esophagus, okay? So when we swallow, this flips down and this flips up, okay? And we get food down the correct pipe. When we speak, air is coming up out of the lungs, passing by the vocal cords, vibrating them, and then is modified by structures in the mouth, okay? So some unique structures here also include the tongue, which is mucus-covered skeletal muscle, covered with a dorsal surface that has papillae with taste buds on it, right? And then there are salivary glands that produce saliva secreted into the oral cavity as well, okay? All right. What holds the upper airway open is the hyaline cartilage, right? The thyroid cartilage, the chrysoid cartilage, and the tracheal cartilages keep the airway patent while the pressure changes in the trachea would normally cause it to collapse if that cartilage wasn't there. The vocal cords vibrate as air passes them. The true vocal cords are medial to the false vocal cords, whose purpose is to block food from entering the voice box and the trachea when you swallow. Okay, so that's the false vocal cords. The true vocal cords produce the sound. Okay? And there it is in a cadaver. Okay? You see some of the structures. The nasal conchae, the first two are part of the ethmoid bone. The last one is its own bone. Their purpose is to promote turbulent flow of air into the nasal cavity, and it helps humidify, warm, and filter it, right? So that's why we have those ridges. During inhalation, the conchae and the nasal mucosa treat the air, and during exhalation, they reclaim a lot of the heat and the moisture. The paranasal sinuses surround the nasal cavity, and you find them in the frontal, sphenoid, ethmoid, and maxillary bones. And what they do is they actually create a large open space connected by labyrinthine passageways from sinus to sinus. They lighten the skull, they serve as resonating chambers, they secrete mucus, and they help to warm and moisten the air. An inflammation of the mucosa is called rhinitis. You know this better as the common cold. Okay, the respiratory mucosa is continuous with the mucosa of the respiratory tract, the upper tract, and it spreads from the nose to the throat, and it can get into the chest, and it can spread to the tear ducts and the paranasal sinuses, and that can cause blocked sinus passageways, and that can produce what's called sinus headache. Okay, this is why when you have a sinus infection, it feels like your eyes are going to pop out of your head because of the pressure behind them, because the paranasals actually surround the superior, medial, and inferior portions of the orbits. The pharynx just connects the nasal cavity to the esophagus, right? It's lined with stratified squamous epithelium in the oro and laryngopharynx, right? And in the nasopharynx, it is simple columnar. Okay. There is skeletal muscle in the pharynx that we use to aid in swallowing. All right. And then in the esophagus, which is the food tube that goes to the stomach, it begins as skeletal muscle and it transitions to smooth muscle on the way towards the opening to the stomach. The three regions: the nasopharynx behind the nose, the oropharynx behind the mouth, and the laryngopharynx behind the voice box or the larynx. Okay. The reason for it being lined with stratified squamous epithelia is to resist abrasion from food and drink and air, you could argue, passing through these areas. Okay. So you can see that pseudostratified columnar epithelium is going to dominate the nasal cavity and portions of the nasopharynx, and that is to move particle-laden mucus out of the nasal cavity, so you can either wipe it away or you can blow your nose, although I don't recommend that. The soft palate and the uvula, we already know, close the nasal pharynx when you swallow. And then we talked about the tonsils at the back of the throat. You've got adenoids on the posterior wall, so-called your pharyngeal tonsils. In addition, in the oral cavity, you've got lingual tonsils, okay? And you also have, you've got the linguals, you've got the pharyngeals, and you've got the palatine tonsils, okay? And occasionally the tonsils will lose the battle against infections and they'll get inflamed. That's called tonsillitis. And then they have to be removed utilizing a tonsillectomy so they don't become a source of infection rather than a defense against it. But you have plenty of lymphatic tissue, even if your tonsils are removed, to fight disease. Pharyngotympanic tube is just a connection between the middle ear and the throat, and its purpose is to equalize pressure on either side of the eardrum. If it gets plugged, the eardrum can get sucked back or pooched out, and if bacteria get trapped in there, they can produce gas, and that can increase pressure on the tympanic membrane, and that's a condition called otitis media. And that often, if it's not treated, ends up in the rupturing of the eardrum. This is extremely painful. Okay, kids get this a lot because their eustachian tubes are very short and straight, and so it's easy for bacteria to go from the throat to the middle ear. The passageway for food and air from the level of the soft palate to the epiglottis is the oral pharynx. It's again lined with stratified squamous epithelia. The isthmus of the fauces is the opening to the oral cavity. The palatine tonsils are in the lateral walls of the fauces, and then the lingual tonsils are on the posterior surface of the tongue. Okay, so you got a total of 5 tonsils, a pair of linguals, a pair of palatines, and a pharyngeal. Okay. Laryngeal pharynx is a passageway for both food and air, and it's right behind the epiglottis and extends to the larynx and also extends to the opening of the esophagus. And it's lined with stratified squamous epithelium. It is critical that the epiglottis close over the glottis when you swallow so that we can direct food down the esophagus and not down the trach, where it could result in a choking hazard. Okay, and again, here we are back at our diagram of the upper respiratory. Okay, the larynx is the voice box. It houses the vocal cords, which vibrate when air passes through them, and that produces sound. Okay, the faster the air goes past, the higher the pitch, and also the higher the tension of the air going past, the higher the pitch. The slower the air going past and the lower the tension in the cords, the lower the pitch. The greater the force behind the air going past the vocal cords, the greater the volume. Okay. The larynx attaches to the hyoid and opens into the laryngeal pharynx and is continuous with your trach. It allows us an open airway, and it routes air and food into the correct channel, and it also houses the vocal cords. The cartilages of the larynx, with the exception of the epiglottis, are all hyaline cartilage. Thyroid cartilage has a laryngeal prominence called the Adam's apple in males. It's much less prominent in females. And then there's a chrysoid cartilage underneath it. And then there are paired arytenoid, cuneiform, and corniculates, which are on the lateral walls and the back of the larynx. Okay, and they're covered with mucous membrane. The epiglottis is elastic cartilage and closes over the glottis when you swallow, along with the false vocal cords, to prevent a passage of water and food into your trach. And there's the larynx from the front, right? There's the hyoid bone, epiglottis, right? Thyroid and chrysoid cartilage, tracheal cartilages, which we'll see in the next view, terminate in the back, so that you allow the space necessary for the esophagus to expand when you swallow. Otherwise, you wouldn't be able to get food down the esophagus and into your stomach. And then you've got membranes, right? Thyrohyoid, chrysothyroid, right? They're named for what they attach to, and chrysotracheal, okay? And these are all ligaments. These are all dense, regular connective tissue, right? This, of course, is compact bone on the outside and spongy on the inside, and is attachment for neck and tongue muscles. Okay. And there it is from the side, and from the side you can see the arytenoids, okay, and you can see the corniculate, and then you can see the cuneiform here in the lateral wall, and there is your vestibular fold, that's your false vocal cord, and there is your true vocal cord here. This is what produces the sound, okay, and then those are your tracheal cartilages. And there it is in a dissection. And there it is with soft tissue covering it, right? The vocal ligaments are deep to the laryngeal mucosa, and they attach the arytenoid cartilages to the thyroid and have elastic fibers in them, and they form the core of the true vocal cords. The glottis is just the opening between the cords, and the folds vibrate to produce sound as the air rushes past them from the lungs. The vestibular folds are superior to the vocals, and they don't play a part in sound production, but they do help to keep food from going down into your trach when you swallow, because they provide lateral protection. As you can see here, the glottis vanishes when the cords are closed, and this is the result of pivoting cartilage at the back that's attached to the cords and changes the tension in them, okay? And it's controlled by skeletal muscle. And then the glottis appears when the cords become slack, right? Or when we speak, make sound, okay? And then you can see some of the other structures, right? The epiglottis here, the base of the tongue, those are the vestibular folds here, the glottis, of course, and then the corniculate cartilage, cuneiform in the lateral wall, okay? And the arytenoids aren't visible because they'd be underneath the corniculates here. So in the larynx, the superior portion is stratified squamous epithelium, and under the vocal cords, it's pseudostratified ciliated columnar, and that forms something called the mucociliary escalator, which is designed to get particle-laden mucus out of the respiratory and up towards the oral cavity, where you can either spit it out or swallow it. In any case, it doesn't end up in the lungs, okay? Voice production is just the movement of air past the vocal cords, causing them to vibrate, in addition to modification from structures in the oral cavity, okay? Pitch is determined by the length and the tension of the vocal cords, as well as the speed of the air moving past them, and loudness is depending upon the force of the air, okay? Chambers of the pharynx include, and the as well as the oral, nasal, and sinus cavities are resonating chambers, okay? So again, if you don't believe me, hold your nose and try to talk, right? And then we modify the sound in the oral cavity. The larynx has vocal cords that can act to close the glottis when we perform something called the Valsalva maneuver, where we tense our abdominal muscles and push without letting air out, right? And that creates force for defecation, childbirth, forceful urination, and so on, okay? The trachea is under the larynx and attaches to the primary bronchi at a structure called the carina, okay, which is where the primary bronchi actually fork off the trach, okay? There are three layers in the trach: the mucosa, the submucosa, and the adventitia. Mucosa is actually multiple tissues. The tissue that lines the lumen is pseudostratified ciliated columnar epithelium. Goblet cells make mucus that traps particulates and pathogens. And of course, the cilia move that mucus up towards the oral cavity, where you can spit it out or swallow it. The submucosa is connective tissue with seromucous glands in it, okay, and it also serves to attach the mucosa to the cartilage and the adventitia, right? The adventitia is the outermost layer, contains connective tissue that encloses the hyaline cartilage that keeps the airway open. The trachealis muscle connects the back part of the cartilage rings in the trach, and it contracts when you cough, and that helps to get irritants out of the upper respiratory. And the carina, of course, is where the bronchi branch off of the trach, and there are a lot of sensory receptors there that are particularly prone to irritation from particulates, and that's one of the things that triggers coughing, so that we don't end up getting stuff down into the bronchi that could interfere with the tissue integrity of the lungs. So you can see here what it looks like, right? There's the esophagus, backside, trachealis. There's the cartilage, right? There's adventitia on the outside, and then here's the mucosa, right? That lines the trach, and then submucosa beneath it with immune cells, okay? And then you can see the cilia lining the lumen of the trach as well, okay? So it truly is an organ, right? Multiple tissues acting together to do something a single tissue cannot. And this is what it looks like in a micrograph, right? Pseudostratified ciliated columnar, okay? Areolar connective tissue here, right? And then submucosa here, which is again connective tissue as well as glands. So there's epithelial tissue in this as well, glandular epithelium, all right? And then you've got hyaline cartilage down here, right? And then you've got a little bit of smooth muscle here and here, okay? So again, multiple tissues doing something a single tissue can't, okay? And this is what it looks like, the surface of the trach in an EM micrograph. You can see the cilia on the surface of the cells. This looks remarkably similar to an EM of the fallopian tubes, which have basically the same tissue lining them, okay? So the air passages undergo about 23 splits to form the respiratory tree that extends all the way down into the lungs, the tips of the bronchial tree to the conducting zone structures to the respiratory structures, okay? So if we take the trip, right, if we inhale, how does the air go, right? We breathe in, the air goes through the external nares, into the vestibule, into the nasal cavity, past the olfactory epithelium, and into the posterior nares, right, that open into the nasopharynx, which leads into the oropharynx, which leads into the laryngopharynx, which is going to lead into the larynx. And we're going to pass the vocal cords going through the glottis, right? And then we're going to go down the trachea, hit the carina, and then go into the right and left primary bronchi, which split into lobar bronchi. There's 3 on the right, 2 on the left, and they split into segmental or tertiary bronchi, and then we continue to branch until we get to the terminal bronchioles, which are the last structure in the conducting division of the respiratory system. You can see the structures here, right? Trach, primary bronchi, secondary bronchi, and then we got tertiary bronchi, right? Quaternary bronchi, and on and on and on until we get to the terminal bronchioles, right? Notice the lobes in the lung, right? There's a superior, middle, and inferior lobe on the right, and there's a superior and inferior lobe on the left, and a cardiac notch on the left to make room for the apex of the heart. This is the oblique fissure, and this is the transverse fissure, and another oblique fissure here, okay? So these are lobes of the lung, okay, 2 on the left and 3 on the right, and those lobes can also be divided into what we call segments, okay? So as we progress from the bronchi to the bronchioles, cartilage rings get replaced by irregular cartilage plates. In bronchioles, elastic fibers are going to replace cartilage. The epithelia changes from pseudostratified columnar to cuboidal, and the cilia and the goblet cells become less frequent, and the amounts of smooth muscle increase, and that promotes the ability to move air to regions of the lung that have the greatest perfusion of blood, okay? The respiratory zone goes from the respiratory bronchioles to the alveolar ducts to the alveolar sacs, and they all engage in gas exchange because of the presence of respiratory membrane in all of these structures, okay? 300 million alveoli make up most lung volume, and that's where the gas exchange happens, and you can see the structures here, right? There's there's respiratory bronchial, terminal respiratory bronchial, okay? Alveolar duct, okay? Alveolar sac, right? And alveoli, okay? And if we look at it in a micrograph, you can see the structures here, okay? Notice how delicate they are and how much surface area you have for gas exchange. If you were to pick up lung tissue that had been preserved, you would swear that it was packing material. It has the consistency of styrofoam, okay? The respiratory membrane is made up of the endothelial cells of the alveoli, the basal lamina, and the endothelial cells of the capillaries. And so it's less than a micron thick and perfect for the movement of gas across its walls. Remember that oxygen and CO2 are nonpolar, so they go right across, okay? There's different cells in the alveoli, type 1, type 2, and type 3, right? The type 1 alveolar cells are called the squamous pneumocytes. They make up the squamous endothelium of the alveoli. The type 2 alveolar cells produce surfactant, which is a detergent that breaks surface tension inside the lungs and makes it easier for the lungs to expand and contract. And the type 3 alveolar cells are called wandering macrophages, and they run around the lungs looking for dead tissue and pathogens to kill. Okay? So that's what the system looks like. Lots of capillaries here. And there is a scanning EM micrograph of the capillaries of the alveoli. The alveoli are surrounded by elastic fibers and pulmonary capillaries. Pores connect the alveoli. They're called pores of cone, and they let the macrophages wander from alveolus to alveolus. Okay? About 2 million dead macrophages per hour get carried by the cilia to the throat, and then we swallow them. Okay? That's part of what goes into the mucociliary escalator. And you can see the different cell types here. Okay? So you got type 3, type 1, type 2. Okay? And the pores. Okay? So look at the membrane, right? Endothelial, and basal lamina, and another endothelial. And then oxygen, CO2 can go right through that. Anything that thickens that layer is going to impede the ability of the lungs to do gas exchange. The lungs occupy the entire thoracic cavity with the exception of the mediastinum. The root is the site of vascular and bronchial attachment to the mediastinum. Costal surface has an anterior, lateral, and posterior region. It's called costal because it is in contact with the costal cartilages of the ribs and the ribs themselves. It's composed primarily of alveoli. The rest is stroma, which is elastic connective tissue that lets the lungs stretch out and recoil when you breathe. So this is a transverse section through the thoracic cavity. You could see the right and the left lung here, right? These are the pulmonary arteries, and the red are the pulmonary veins. Remember, the pulmonary veins return oxygenated blood back to the left side of the heart. And then you can see the pleural cavity, right? This is the parietal pleura, and then the visceral pleura clings to the organ, and between it is the pleural fluid, and that lubricates the outside of the lungs so that you can inhale and exhale without irritation, inflammation, and scarring. Very important. Okay? The lungs have an apex, which is the superior tip that's just underneath the clavicle, and a base, which rests on top of the diaphragm, and the hilum, which is on the mediastinal side, would be the medial sides of the lungs, and it's where the bronchi and the blood vessels, lymphatics, and the nerves go in and out. And we talked about the cardiac notch in the left lung, right? And the fissures as well. So the left lung really is just there to assist in breathing. The bulk of the respiration and the ventilation happens in the right lung, okay? So the right lung with 3 lobes, right? And it has about 10 segments in those 3 lobes, a total of 10 segments separated by connective tissue, right? And on the left side, we have between 8 to 10 segments in 2 lobes, okay? So if a lobe goes bad, we can take the lobe out and the integrity of the lung can be maintained. The lobules are the tiniest subdivisions, and they're served by bronchioles and their branches. Okay, so you can see here the fissures, the membranes, the diaphragm, right, and the lobes of the lung, okay, as well as portions of the trach, right. So there's your respiratory. There is preserved lung from the back. See the pulmonary arteries and veins and the bronchi going in and out, right? And you can see the lobes of the lung as well, okay? And there is the bronchial tree. The bronchial tree is formed by pouring latex into the trachea of dissected tissue and then letting it harden. And then you dissolve the tissue by treating it with powerful base, like sodium hydroxide, and you end up with this cast of where the conducting division of the respiratory system goes, okay? So you can see that it gets to every square inch of the lung. It's very extensive, okay? And then you can see by the color coding here the different segments that are in each of the lobes of the lungs as well, okay? So very extensive ventilation. right? The blood supply here is low pressure, high volume. Remember that the amount of blood that is pumped out by each side of the heart with each beat is always the same, but on the right side, we're talking low pressure, low force, where on the left side of the heart, we're talking high pressure, high force, okay? So the pulmonary arteries bring deoxygenated blood to the lungs where oxygen is exchanged for CO2, and the pulmonary veins bring oxygenated blood back to the left side of the heart from the respiratory zone, okay? The lung capillary endothelium also has enzymes that act in the blood, such as ACE, which converts angiotensin 1 to angiotensin 2. And as we learned in the circulatory chapter, that's critical for the regulation of blood pressure. Okay? The bronchial arteries provide oxygenated blood to the lung tissue. They come from the aorta and they enter the lungs at the hilum, and they're part of the systemic circulation. Again, high pressure, low volume. Okay? They supply all lung tissue except for the alveoli. The bronchial veins anastomose with pulmonary veins, and so pulmonary veins carry most venous blood back to the heart. Okay? So this is an unusual situation in which you have bronchial veins, which are going to be filled with oxygen-poor blood, mixing with pulmonary veins, which are oxygen-rich blood. Okay, but both are going back to the left side of the heart. Okay, the pleurae are just the membranes that surround the lung and the cavity in which they sit. The parietal pleura clings to the cavity, and the visceral pleura clings to the lungs themselves, and between them, pleural fluid lubricates the lung so it can expand and contract without producing irritation, inflammation, and scarring. Okay? An inflammation of these membranes is called pleuritis or pleurisy, and it's extremely painful. Okay? So again, we can see the membranes that surround the lungs, right? Remember that these are all double-layered membranes with fluid between them. Parietal layer, fluid, visceral layer. Okay? Serous membranes always are found in cavities that are not supposed to be exposed to the outside environment. When we breathe, we go through two cycles. One, a cycle of inspiration, where we pull gas into the lungs because we can create a negative pressure, and expiration, where we can push gas out of the lungs because we create a positive pressure. Okay? Atmospheric pressure, which is 760 millimeters of mercury, is the force of the atmosphere on the surface of the earth and on your body. Okay? Respiratory pressures are described relative to atmospheric. Okay? They can either be equal to, greater than, or less than atmospheric pressure. If they are greater than atmospheric pressure, then they will force air into the atmosphere. If they're less than atmospheric pressure, air from the atmosphere will go into that region. And if they're equal, there will be no net movement. Okay? So intrapulmonary pressure is in the alveoli themselves, and it changes as we breathe in and out, but eventually equalizes to atmospheric pressure. Well, intrapleural pressure fluctuates when we breathe, but it's always going to be slightly negative in order for the lungs to remain patent while we breathe in and out. Okay, that's one of the reasons why if you rupture the chest cavity, the lung can collapse, and that's a condition known as atelectasis. Okay, and that needs to be fixed by sucking out the gas that goes through the sucking chest wound, and then restoring the pressure inside the lung, right, and a negative pressure outside the lung. The fluid level here has to be minimal. What will happen if we generate a positive pressure is it will have lung collapse as well, right? And the lymphatics take care of a lot of this. That's why there's so many lymph nodes in the thoracic cavity. Negative intrapleural pressure is caused by two opposing forces. The hydrogen bonding of the moist surfaces of the interior of the lung tends to pull the lungs inward. Elastic recoil of the lungs also tends to contribute to this. And the outward force is the elasticity of the chest wall that pulls the thorax out. Okay, so they balance so that the lungs stay open most of the time, right? Although they will vary in size as you breathe in and out. If intrapleural pressure is equal to pulmonary or atmospheric pressure, the lungs will collapse. If pulmonary pressure minus intrapleural pressure results in a transpulmonary pressure, the size of the lungs will depend on the amount of transpulmonary pressure. The greater the transpulmonary pressure, the larger the lungs are going to be. Okay, so you can see here where these pressures are measured, right? Transpulmonary between the interior of the lung and the pleural cavity, right? Intrapleural within the pleural cavity, right? And intrapulmonary within the chamber of the lungs themselves. Okay? A telangiectasis or lung collapse is due to the accumulation of fluid or air in the chest cavity. Okay? Pneumothorax is air in the chest cavity. Hemothorax is blood in the chest cavity. And this can result from a penetrating wound, or it can result from rupture of the lungs from the inside out. And what we have to do is get the air out, patch the hole, and restore the pressure difference. Okay? Pulmonary ventilation is just the act of inspiration and expiration that moves the air in and out of the lungs. Okay? Remember that there is a law called the perfect gas law. Okay? So let me write the perfect gas law up here. That is fine. There's the pen. Perfect gas law states that PV is equal to nRT at all times. Okay. PV equals NERT. Okay. What the heck is P and V and NERT? Well, P is pressure, V is volume, N is the number of moles of gas, R is a constant, and T is temperature. Okay. So this is always true. Okay. And what this tells us is that that pressure and volume are inversely related, pressure and volume are directly related, directly proportional, right? And that temperature and volume are directly proportional, okay? And that if we rearrange the equation, we get PV over T, right, is equal to the number of moles of gas times a constant, right? And that tells us that as the number of moles of gas increases, okay, that the volume and the pressure are going to go up, okay? So you get a lot of stuff out of this equation, okay? We can rearrange it so that nRT is equal to nRT over volume is equal to pressure, okay? And that tells us that as the volume goes down, the pressure goes up, and as the pressure goes up, the volume goes down, okay? And that's the pressure applied to the gas, okay? Right? So volume tiny, pressure high, right? Volume big, pressure low, right? Temperature high, temperature low, pressure low, okay? Those are your relationships, okay? The other laws are just variations of this law, right? Boyle's law states the relationship between pressure and volume of gases, right? If the container size is reduced, the pressure will go up, right? So pressure and volume inversely related, right? And then we have Avogadro's law, which states that if the number of moles of gas goes up, the pressure goes up, okay? Inspiration is an active process that involves the diaphragm, and under forced inspiration, it also involves the sternocleidomastoid, the scalenes, the external intercostals, okay, and the pec minor, okay, which will flare and expand the thoracic cavity outward, okay. Air will flow into the lungs down its pressure gradient until pulmonary pressure and atmospheric pressure are the same, and at that point, net movement stops. Okay? But in forced expiration, what happens is that accessory muscles come in, and you can see what happens is that we expand the size of the thoracic cage even more, and the result is that we're able to pull more air in, and that gets more oxygen into the blood, and that gets more oxygen to the tissues, including the muscles, and we can sustain the activity longer. Okay? In expiration, this is normally a passive process. Okay? The inspiratory muscles relax, the diaphragm relaxes, and recoil takes care of the rest. But if you do forced expiration, blowing hard, right, that's an active process using the abdominal and the internal intercostal muscles, as you can see here, right? Abdominals contract, internal intercostals contract, the rib cage shrinks, positive pressure on the outside of the lungs goes up, and the air is forced out. Notice the differences that take place in pressure and volume during a normal breathing cycle, right? So here we're just measuring, again, different pressures, right? The intrapulmonary pressure, the pressure inside the lungs, all right? As we breathe in, it goes down, creates a vacuum, and in goes the gas. And then as we breathe out, right, it goes up, okay? So that's easy enough, right? The intrapleural pressure tracks, right, down and then up. That's the pressure within the pleural cavity. And the transpulmonary pressure is going to always remain negative, right? But how negative depends on whether we're at the midway point or the inspiratory or the expiratory point in the breathing cycle. The volume of air expelled is going to maximize at the end of inspiration and the beginning of expiration, right? And it will go down as the air escapes, okay? So in comes the air, out goes the air, right? Three factors can inhibit air passage and pulmonary ventilation. They include airway resistance, alveolar surface tension, and lung compliance, okay? So all of these, unfortunately, get worse as we age. And that's one of the reasons it's harder for us to be active and maintain our health, okay? The lung compliance gets reduced because of scar tissue. The surface tension becomes greater because surfactant production goes down. And the airway resistance increases, again, because of the accumulation of damage in the upper airway and the loss, in many cases, of areas of the lungs to blockage, right? We lose a certain volume of our lungs due to them scarring and due to the pipes that go into them getting blocked over time, okay? So friction is a non-elastic source of resistance to gas flow, okay? And it happens in the airways. Note that the relationship between flow, pressure, and resistance is as shown here. The difference in pressure over the resistance is equal to the rate of flow, right? So the greater the difference in pressure, the greater the rate of flow. The greater the resistance, the less the rate of flow, okay? So you always have to have a pressure gradient for net movement to occur. If there's no pressure gradient, net movement stops, all right? So resistance is usually insignificant because of large airway diameters in the first part of the conducting zone, and the progressive branching of the airways gets smaller, the total cross-sectional area goes up. So the resistance is actually greatest in the medium-sized bronchi, and it disappears at the terminal bronchioles where the diffusion takes place. So you can see here, right, how the resistance changes. It's low, then it kicks up in the medium-sized bronchi, and then it drops, and down it goes. Now, there are exceptions to this, and damaged lung tissue with scar tissue in it, it can peak at the medium-sized bronchi, but it can descend at a much lower rate as we head to the terminal bronchioles, okay? And that can be the result of things like cigarette smoking and exposure to irritants. And those are called restrictive pulmonary disorders. We'll learn more about them in Part B, okay? As airway resistance goes up, breathing movements get more strenuous. Severe constriction or obstruction of the bronchioles can prevent ventilation and can occur during asthma attacks, which is an example of a reversible obstructive pulmonary disorder, and that can stop ventilation, right? And this is why they usually carry albuterol or epinephrine with them to promote bronchodilation, to open those airways back up so that they can restore flow and breathe again, okay? All right, surfactant is what we use to break the surface tension inside the lungs that promotes lung collapse, right? The inside of the lungs are moist, and the hydrogen bonding tends to cause the lungs to try to squeeze shut, okay? And so to get around this, surfactant produced by the type 2 alveolars is designed to overcome that because of its detergent action. And the result is we can breathe in and out with relative ease, okay? In preemies, the production of surfactant is reduced, and we often see a condition called IRDS, which stands for Infant Respiratory Distress Syndrome, and we have to give them surfactant in order for them to be able to breathe because their type 2 alveolars are not up to speed yet, okay? Compliance is just the stretchability of the lungs, okay? And it's generally high because of the normal distensibility of lung tissue and the alveolar surface tension being broken by surfactant, okay? But it can be diminished by scar tissue, reduced surfactant production, and decreased flexibility of the thoracic cage. And guess what? All of those happen as we age, okay? Homeostatic imbalances that reduce compliance include abnormally shaped thoracic cage, ossification of costal cartilage, basically the joints between the ribs and the vertebrae and the ribs and the sternum, they mineralize, right? And then intercostal muscles getting weaker or getting paralyzed, right? And all of this means it's more tougher for you to take a good deep breath, okay? We talked a little bit about this in lab, but what you have to remember here is that one of the ways we can determine the efficiency of ventilation, meaning the mechanics of ventilation, is through spirometry. And these are some of the volumes that we can measure, okay? Combinations of volumes shown here, right? So let's take a peek and go through some of these, okay? They're all listed here. So let me get the laser out, okay? There we go. Great. Well, let's use red here. We'll go laser pointer. Okay, so you have to imagine a very old-timey piece of equipment here. Basically, you're blowing into a tube that's connected to a liquid-filled drum that has on top of it a more narrow diameter air-filled drum. And so as you blow into the tube, the air from your lungs causes more gas to collect above the liquid, and that raises the smaller cylinder up. And it's the smaller cylinder that has a pen attached to it, and that pen will rise and fall as it writes on another revolving cylinder, okay, that records these volumes like you're seeing here, all right? So essentially, as you breathe in, right, the pen will rise up, and as you blow out, the pen will dip down, okay? That's the way that the device is set up, okay? So this is called your tidal volume, all right? And this is the amount of air that you can blow in and out in a normal, relaxed breath. It's usually half a liter, all right? Your inspiratory reserve volume is everything above the tidal, okay? So it's this right here, all right? And this represents how much air you can pull into your lungs with a maximum effort. Your expiratory reserve volume is how much you can blow out of your lungs after a normal exhalation, okay? And then we have the residual volume, which is the amount of air that remains in the respiratory system even after a maximum inhalation and exhalation. And that's called the residual volume. And all that does is hold the airways open. The distance from this peak to this trough is called the vital capacity. So what that is, that's max in, max out, all right? So if you were at a spirometer, you would not hold this in your mouth. You would hold it to the side. You would take as deep a breath as you possibly could, and you'd put the hose in your mouth, and then you blow out as hard as you possibly can, okay? That is a vital capacity. And then we have combination volumes, right? Inspiratory capacity is the combination of your vital and your inspiratory reserve. And then functional residual is your residual plus your expiratory, okay? And then there's your expiratory capacity, which is your tidal plus your expiratory reserve, okay? That doesn't have to be listed on here, but there it is. And your total lung capacity is just your residual plus your vital, okay? So the more effective you are at performing these different maneuvers on the spirometer, the better shape your ventilation apparatus is, okay? Now, there are two classifications of pulmonary disorders that we need to be aware of: obstructive and restrictive, okay? In an obstructive pulmonary disorder, you've got a block somewhere in the pipe, all right? And what you generally see in an obstructive pulmonary disorder is that your forced expiratory volume over your forced vital capacity starts to drop, okay? Your forced expiratory volume is the expiratory volume in a set period of time, okay? Usually it's like a minute, okay? Your forced vital capacity is essentially your vital capacity in that block of time, all right? And what happens is that as that ratio falls, that's an indication of an obstructive pulmonary disorder, all right? In a restrictive pulmonary disorder, your lungs can't expand the way they want, all right? They're locked at a smaller volume either because of scar tissue or a deformed thoracic cage or obesity, okay? Just a few examples. And what happens there is that your vital capacity goes down, right? So when we do spirometry, we can pick up one or both of these, and we know what might be affecting you. The dead space doesn't contribute to gas exchange. It's just the air in the conducting division after a vital capacity. It's usually around 150 mil. Alveolar dead space is non-functional alveoli because they're blocked or they've collapsed, and total dead space is both the anatomical and the alveolar dead space. We all have some of that, right? The spirometer is just the instrument used to determine these things, okay? There are different kinds of spirometers. There's digital spirometers, there's dry spirometers. The one I described is an old-fashioned wet spirometer, okay? And they're there to differentiate between obstructive and restrictive disorders, okay? And you can see here, in a restrictive disorder, your vital capacity, your total lung capacity, and your residual volume are going to drop, okay? In an obstructive disorder, you're going to have more airway resistance, okay? Your total lung capacity and your forced residual capacity, functional residual capacity, may drop, but your residual volume may increase because of gas trapping. Okay, and that's where you can't blow out as much air as you want because it gets trapped inside of areas in the lungs that are surrounded by scar tissue. Okay? To measure the rate of gas movement, we can take a forced vital capacity and a forced expiratory volume. Your forced vital capacity is the gas that's forcibly expelled after a deep breath, and your forced expiratory volume is the amount of gas expelled during specific time intervals of the forced vital capacity. Okay? Your minute ventilation is the amount of gas that you move in or out of the tract in a minute. Normal at rest is about 6 liters a minute. With exercise, about 200. And it's a rough estimate of efficiency. Okay? A good indicator of effective ventilation is alveolar ventilation. The AVR is the flow of gases into and out of the alveoli in a particular time, where the dead space is held constant. Generally, rapid shallow breathing is going to decrease the AVR. Okay? Non-respiratory air movements move air in and out, but they don't engage in gas exchange. Okay? Examples include coughing, sneezing, hiccups, yawns, and so forth. Okay? And then we've talked about the differences in the types of respiration, right? The external respiration is the movement of gas in the lung to the blood, internal from the blood to the tissues, and cellular respiration is the use of oxygen within the cells to generate ATP through the electron transport chain. Both internal and external respiration involve the physical properties of gas and the composition of alveolar gas. All right. One of the things we have to understand about the air we breathe is that it is a gas mixture. It's 80% nitrogen and about 20% oxygen, and the rest is the other gases, okay, rare gases, including CO2. It's a very tiny amount of the air that we breathe, okay? And so the partial pressure is the percentage of that gas in the mixture, and you take that percentage and multiply it by the total pressure of the gas mixture, right? So if nitrogen is 80% of the air we breathe, then the partial pressure of nitrogen is 0.8 atmospheres in that gas mixture. Okay? Henry's law refers to gas mixtures that are in contact with liquid, and each gas will dissolve in proportion to its partial pressure. The greater the pressure, the greater the amount of gas you force into the liquid, and at equilibrium, the partial pressure will be equal. The amount of gas that will dissolve depends on the solubility and the temperature. Now, this is a little weird because it turns out that gases dissolve more easily in water the colder the water is. Okay? And the best analogy I can draw is soda pop, right? If you want to keep the carbonation in your soda pop, what do? You keep it cold, right? If you want it to go flat, what do? You warm it up, okay? CO2 is 20 times more soluble in water than oxygen, and nitrogen and oxygen don't dissolve very well in water because they're nonpolar. Oxygen about 9%, nitrogen a little less, okay? The reason for the solubility of CO2 is that CO2 and water form carbonic acid, all right? So that helps the CO2 go into solution. And also the fact that CO2 has more polar character as a nonpolar gas than either oxygen or nitrogen. So temperature and solubility, right? The alveoli contain more CO2 and water vapor than atmospheric air, and that makes sense because their surfaces are moist, okay? Gas exchanges in the lungs through those moist surfaces in the respiratory membrane, and we mix alveolar gas with each breath we take, okay? And so you can see the difference between the percentages of gas at sea level, right, and their partial pressures. This is in millimeters of mercury versus in the alveoli. And the main thing to remember in the alveoli is that we're going to jack up the amount of CO2 that's in there and the amount of water, okay? And that is reflected here in the partial pressures, okay? External respiration is going to be influenced by the thickness and the surface area of the membrane and the partial pressure gradients and the gas solubilities, and also what we talked about earlier, which is this ventilation perfusion coupling. We talked about the fact that the respiratory membrane is less than a micron thick generally, and the huge surface area allows effective gas exchange. Let's talk about a few of these, okay? In emphysema, what happens is that particulate-laden mucus drops down into the lungs and causes them to irritate, inflame, and scar and coat with mucus, okay? So you do two things here. You destroy alveoli, you scar up alveoli, and you coat them with gunk, right? And so it's very hard for you to get a breath in that adequately oxygenates your blood, okay? That's why people with emphysema are sucking wind just walking upstairs, okay? Lung cancer is where metastatic tissue sets up in the lungs and destroys the lung tissue and replaces it with tumor tissue. So what's happening here is you're removing surface area from the lungs and you're replacing it with something that's going to invade and destroy normal tissue. In addition to the fact that it's going to steal some blood supply from the lung tissue as well. Along with that come white blood cells. Histamine production causes fluid accumulation, and the action of the white blood cells can sometimes damage healthy tissue. And the result is you're thickening the membrane, the respiratory membrane, and you're cutting down on the ability of the gas to get into the blood and out. And then finally, mucus production. One of the places where this is most dramatic is in a condition called cystic fibrosis, okay? In CF, what happens is that you make a mucus that has too much sodium in it, and that causes it to pick up more water than it otherwise would, and it acts as a culture medium for the bacteria in the air that you breathe, and they begin to grow and die in the mucus, and that thickens the mucus even more, and that clogs the respiratory membrane, and it also over time scars it, okay? And so CF is a genetic disorder. It is an autosomal recessive, okay? So we can tell if you're going to be born with it by doing amniocentesis. The gene was actually discovered at Cincinnati Children's. There is no fix. There is a treatment, which is to use an ambivest, which generates percussive force on the chest cavity and allows you to expel the mucus so that you can breathe. And then we can use mucolytics, which among them include DNase, which breaks down the DNA in the mucus, which is generated when the bacteria die and lyse, okay? And that can thin the mucus and make it easier to get rid of. But there's no way to repair this until we have the ability to actually go in and fix genes within cells. This is an inborn error at birth. So how is it that we're able to adequately oxygenate the blood? And the answer is that there's a big partial pressure gradient for oxygen in the lungs that allows the rapid diffusion of the oxygen from the air that you breathe into the blood that's coming to the lungs from the heart, in addition to the fact that we have, thank goodness, hemoglobin in our red blood cells that will bind that oxygen and maintain that gradient, okay? If we didn't have the hemoglobin, we could only force the oxygen in there at about 9%, and that's not enough for us, okay? The venous pressure for oxygen is 40 millimeters of mercury, and the alveolar pressure is 104. So that's enough to drive the oxygen into the blood in about a quarter second, which is about a third the time a red blood cell in the pulmonary capillary takes to go from the arteriole to the venular end. Okay? So that's more than enough time to get the job done. Right? And so you can see from the start to the end of the capillary how quickly we get to full oxygenation. All right? Shown here. CO2 is a little different. The gradient's not as steep, but the solubility properties are very different. Okay? So the CO2 diffuses in equal amounts with the oxygen because the carbon dioxide is 20 times more soluble in plasma than the oxygen is, and that's for a couple of reasons. Number one, it forms carbonic acid all by itself when it comes into contact with water. And number two, there happens to be an enzyme inside the red blood cells that converts the carbon dioxide in water into carbonic acid very rapidly. Okay? And the result of that is you can dump a lot of CO2 into the blood as a result of this increased solubility, in addition to the fact that, again, CO2, even though it's technically a nonpolar molecule, has more polar character than oxygen does. And there you can see the changes in oxygen and CO2 in the pulmonary and the systemic circuits. Okay? And remember, this is all driven by diffusion. Now, ventilation-perfusion coupling is a method that the lungs use in order to get blood and inhaled air to meet up in the lungs in the most effective way, such that areas of the lungs with the greatest ventilation become the most perfused. Okay? So areas of the lungs that are high oxygen get high blood delivery, and areas of the lungs that are low oxygen get low blood delivery. This is the reverse of the way it is in the systemic circulation. And the reverse is also true. Areas of the lungs that are well perfused get well ventilated. Okay? And it's the action of smooth muscle in both the bronchioles and in the arterioles that's able to pull this off, right? And in the thoroughfare vessels, okay? And so the idea here, again, is to get that matchup to be the most efficient possible, okay? Changes in oxygen levels in the alveoli cause changes in the arterial diameter. Where alveolar oxygen's high, the arterioles dilate, and vice versa, okay? Changes in CO2 levels cause changes in bronchial diameter. Where alveolar CO2 is high, bronchioles dilate, okay? Where alveolar CO2 is low, bronchioles constrict, right? And this allows elimination of CO2 more easily. So you can see here how this is working, right? Ventilation less than perfusion on the left, right? And ventilation greater than perfusion on the right, okay? Capillary gas exchange in body tissues is internal respiration. Partial pressures drive this. Again, remember, when we're talking about movement of gases, it's all driven by concentration gradients. Tissue oxygen is always going to be lower than in systemic arterial blood because we're using oxygen in order to generate ATP, and we're converting it into water, all right? So that's what's happening in metabolically active tissue. So that's why the oxygen levels there are always lower than in arterial blood. CO2 is always higher. Why? Because CO2 is the waste gas that's generated from the three legs of metabolism: glycolysis, the Krebs cycle, and the electron transport chain. Okay? Venous blood, partial pressure of oxygen is about 40 millimeters of mercury, and the CO2 is about 45. Okay? So again, we're back to our diagram of diffusion gradients. Just notice, right, that in the lungs, the gradient for oxygen into blood is steep for going from the air into the blood, and in the tissues, that condition is reversed, right? That's the take-home message here. All about diffusion gradients. How do we move oxygen and CO2? The main way we move oxygen is bound to hemoglobin. Bottom line, 1.5% is dissolved in plasma. That's pathetically little. Right? We couldn't live on that, okay? So we needed a vehicle in the blood to transport the oxygen, and that's where the hemoglobin comes in, okay? 4 oxygens per hemoglobin molecule, millions of hemoglobin molecules in any red blood cell. Oxyhemoglobin is hemoglobin bound with oxygen, while reduced hemoglobin is hemoglobin that is not fully saturated with oxygen. Okay, deoxyhemoglobin is a dark red. Oxyhemoglobin is a nice bright red. Okay, loading and unloading of oxygen is aided by changes in hemoglobin. Okay, the Bohr and the Haldane effect come in here. All right, so hemoglobin is interesting because conditions that prevail in tissues produce changes in hemoglobin shape that make it more likely to unload its oxygen. So what are those conditions? Low pH, higher temperature, okay, and lower oxygen and higher CO2 levels, all right? And all of those promote changes in the hemoglobin shape that make it less likely to bind its oxygen tightly and makes it easier for the oxygen to move from the hemoglobin into the tissue fluid and into the cells, okay? The reverse is the case at the lungs, right? The pH is higher, the temperatures are lower, okay? The oxygen gradient is reversed, okay, such that the oxygen tends to want to come into the RBC and bind to the hemoglobin, okay? And the CO2 gradient is reversed, okay, such that it's going to flow out of the RBC, out of the plasma, and into the expired air. Hemoglobin's fully saturated if all 4 heme groups are oxygenated, and partially saturated if that's not the case, right? When we either have 3 or fewer. Okay? The rate of loading and unloading of oxygen is regulated by the gradient of oxygen, the temperature of the body, the pH, and the concentration of CO2, as well as the concentration of bisphosphoglycerate, which is generating during glycolysis and rises when oxygen levels are low. Okay, so what you're looking at here is an S-shaped curve called a dissociation curve, and it represents the fact that binding in hemoglobin has something called cooperativity, where when the first oxygen binds to the first hemoglobin, the shape of the tetramer changes so that the subsequent binding is much easier. Okay, so that first oxygen has to really squeeze in there tight, but then it opens up for all the other oxygens that come afterwards. Okay, so what you're seeing here is that as the oxygen concentration goes up, the hemoglobin saturation goes up in an exponential fashion. This is an S-shaped curve, all right? This represents a rapid rise in oxygenation, and here the rise isn't as significant, okay? So what do we see, right? In the tissue of other organs, where oxygen is low, about 40 millimeters of mercury, hemoglobin gets less saturated with oxygen. Why? Because it's giving up what it had bound to it, right? And then over here in the lungs, where oxygen levels are high, hemoglobin is fully saturated, right? So this is in the alveoli, right? In the capillaries that are near the alveoli. This is in the tissues, okay? And then as we change the conditions to have lower oxygen concentration, the saturation goes down and down and down, okay? So what this is telling you is that we're going to load in the lungs and we're going to unload in the tissues, okay? Why is this the case? Well, let's look at oxygen levels, all right? When oxygen levels in arterial blood are at about 100 millimeters of mercury. This has about 20 mils of oxygen per 100 mil of blood, so it's 98% saturated. Further increases in oxygen don't generate much increase in oxygen binding. We're pretty much maxed out, right? But in venous blood, the oxygen's about 40 millimeters of mercury, has 15% volume saturated of oxygen, but the hemoglobin is 75% saturated, okay? So the venous reserve is the oxygen that remains in venous blood even after we've dumped off what we need to the tissues, okay? And this is enough to give us 5 minutes without tissue damage if our heart stops. This is our oxygen reserve, okay? Beyond 5 minutes, we use that up, and we have coma and then death, okay? So, what do we see here, all right? Here's an adjustment that takes place in high altitudes. In high altitudes where the air is thin, what happens is that we end up with less oxygen in the air that we breathe, and so what will happen is that the hemoglobin will even here be 95% saturated in thin air, but if we remain at high altitudes, erythropoietin production will go up and the hematocrit will rise to compensate for that, okay? And so eventually we'll get to the point where in terms of total oxygen in the blood, we're carrying the same as we are at sea level, okay? So this is one of the reasons why in professional sports over many seasons, it can be shown that the best records are held by the teams that play at high altitudes. The Colorado Rockies, the Denver Nuggets, the Denver Broncos, the Colorado Avalanche have better home records. This is again over many seasons than other home teams because teams that come from sea level up to mile high in the late stages of the game get tired. And the result is that the high altitude team can kick their butt. Okay? We've seen this with the Bengals several times at Mile High Stadium. Okay? So, this is one of the tricks you can use, legal tricks, to beat the pants off somebody in an endurance event, which is to train at high altitudes. This is sanctioned by professional organizations. So if you want to box or play basketball or whatever the event is, if you train at high altitudes and got your crit up, then you can go down to sea level and beat the pants off of everybody that didn't. Okay? It's illegal to cheat the system to get there. So you can't inject yourself with erythropoietin, and you can't do what's called blood doping, which is where you donate a unit of blood and you save it till before the event, and then they transfuse it back into you. You're not allowed to do that. Okay? And the erythropoietin use was what busted Lance Armstrong, right? That's why he got stripped of all his Tour de France titles. But training at high altitudes is legit. Okay? Okay. Increases in temperature are going to cause the affinity of hemoglobin for oxygen to go down. The same with decreases in pH, the same with increases in CO2 and bisphosphoglycerate. Okay? What they do is they change the shape of the hemoglobin and they make it more likely to cough up its oxygen to the surrounding tissue. The result is what we want, right? Which is the ability of this unique oxygen transporting protein to give up its payload where we want it to give up its payload, which is in metabolically active tissue, which is warmer, has a lower pH, has a higher CO2, a lower oxygen concentration than in the blood that's coming to it through the arterial delivery. Okay? So what will happen is that all of these will tend to shift the oxygen hemoglobin dissociation curve to the right, which means less affinity, right? Whereas if we switch those factors the other way, the oxygen hemoglobin curve will shift to the left. Okay, so you can see some examples of that here, right? Let's look at temperature. Let's take normal body temperature here, 38, right? Now let's take higher temperature, 43, right? Look what happens to the affinity. Let's take, I don't know, let's just pick the 50% level, which is going to be about here, right? All right, at a much lower oxygen concentration, right? But the 50% level here, right, is going to require a much higher oxygen concentration, okay? So you can see the effective temperature. As the curve shifts to the right, the affinity goes down. How about oxygen levels, right? So we're looking at oxygen saturation at different CO2 levels. Notice as the CO2 levels go up, this is normal CO2, this is increased CO2. See the curve shift to the right. And again, let's just take the 50% mark, right? 50% mark here at normal CO2 levels, right? You require, let's call it 25% or 25 millimeters of mercury oxygen, right? Whereas the same on the higher CO2 end, you're going to require about 35% oxygen, okay? Why did this happen? Two reasons. The CO2 binds to the hemoglobin and changes its shape at amino groups, making something called carbaminohemoglobin. And the other reason is that the CO2 is going to produce carbonic acid in the presence of carbonic anhydrase. And those protons are going to bind to the hemoglobin and change its shape and make it more likely to give up its oxygen. Okay? So those are the Bohr and the Halbane effects. Okay? So there it is, right? CO2 and proton levels go up, declining blood pH and increasing CO2 levels produce the Bohr effect, where the hemoglobin oxygen bond weakens and the oxygen gets coughed up. Heat production increases, and that indirectly decreases hemoglobin affinity and releases oxygen to the surrounding tissues as well. Okay, so those are major players. All right, and those are inherent effects of the properties of hemoglobin. Right, that's in its genetic information, and that's exactly what we want out of an oxygen-carrying pigment. Without hemoglobin, we couldn't get enough oxygen into the blood to allow us to survive, right? Because we can't dissolve enough oxygen in water for that to happen. All right, so we are very lucky to have this molecule at our disposal. Okay, so with that, we'll cut it, okay, and we'll pick the rest of this up on the back end.